Hi, and a warm welcome to all of you today who have taken time to come out of your busy schedules. The only thing that pumps us up, no matter what the situation is the heart. And taking care of that heart is our responsibility. Hi, everybody. My name is Hiba, and it is my pleasure in welcoming all of you to the webinar on the four pillars of atrial fibrillation management presented by Kauvery Hospital under the Hindu Wellness Series. And with the topic being four pillars, we have our four pillars with us who will be our panelists. I would like to extend a warm welcome to Dr. Deep Chandraja, Dr. T. Joseph, Dr. Srinivas Sivarajan Tandeshwaran, and Dr. Srinivas Rajagopala. So, with that being said, let us kickstart this webinar. Our first speaker will be Dr. Deep Chandraja. He is a consultant cardiologist and clinical lead cardiac electrophysiology at Kauvery Hospital, Chennai. He's recognized as an accomplished and renowned cardiac electrophysiologist in India, having received his formal training at the prestigious Australian National University. With extensive experience, Dr. Raja has performed more than 5,000 cardiac EPS, RFA, and pacemaker procedures. He has contributed significantly to the field with over 50 international publications to his name. His educational qualifications include MBBS, MD, DM, DNB, and FNB in interventional cardiology, along with a fellowship in advanced clinical electrophysiology. Doctor's area of expert lies in cardiac electrophysiology and pacing. He will now make his presentation on an introduction to atrial fibrillation. Welcome, sir. The floor is all yours.
Thank you. Thank you, Hiba, for that warm welcome and a nice introduction. So let me confirm my voice is audible to all? Yes.
Yes, sir. Well and
Good.
clear.
Good. Thank you. So let me start uh, my screen, sharing my screen here. Okay. So, yes. In this wellness series, we are very happy to take up this topic of atrial fibrillation management, the four pillars. This is a rhythm problem which needs a multidisciplinary management. And hence, rightfully, we have experts in the panel from the field of uh, neurology as well as pulmonology and sleep medicine. Myself and Dr. Joseph Theodore will be the cardiac electrophysiologist in this panel. We have coincided or set up this in line with the World Heart Rhythm Week, which is on. It is already we are in the World Heart Rhythm Week. This is a was formulated by the Heart Rhythm International Heart Rhythm Societies, so as to doctors promote and this field of heart rhythm, and to let the people and the public audience know what are the heart rhythm problems going on and how do we deal with them. This is a whole new field, but not much known to the public, and hence our duty here is to make the awareness for the public and as well as to the doctors and the general physicians. So atrial fibrillation is one of a very common heart rhythm problem. The normal heart rhythm is rate and regular, which is very much between 60 and 100 beats per minute at rest, and a beat of lub dub at a regular rhythm, a beautiful heart music. But then, when there is atrial fibrillation, the heart goes chaotic. It just beats randomly fast. We have a political climate and a political situation now. So I would rather put an analogy of an upper house is out of order. Heart has an upper house and a lower house. The upper house is completely out of order. There's chaotic activity in the upper house. That causes these fast and irregular heartbeats. That's what we call as atrial fibrillation. We fondly call it AFib. Shortly, the doctors call it AFib. It is the most common heart rhythm problem, and the incidence is almost 1 in 20 people more than 40 years of age. And the incidence increases in elderly. For example, more than 80 years of age, 1 in 10 do have this problem of atrial fibrillation. What are the common symptoms of atrial fibrillation? The most common symptom of atrial fibrillation is palpitations. Just like Jerry feeling his heartbeat, anyone would feel that heartbeat going fast, pounding, the heart pounding fast because the heart is beating very fast, at least at 180, 200 beats per minute, and also irregularly. So that is palpitations is the number one symptom. Shortness of breath is the second symptom, and breathing, lightheadedness, and dizziness. Remember, the heart is going at a rate of 180 to 200. So it's not unusual and it's not uncommon for one to feel the head spinning because that's not enough blood supply to the brain. The four pillars of management of AFib. One is risk factor management, which is both understanding what causes atrial fibrillation, how do you avoid these risk factors, and then the stroke risk, the link between stroke and AFib, and the last is the rate control and the rhythm control of atrial fibrillation management. So we have four experts here talking of each about each pillar of management. Let us start with the risk factor reduction. Over to you, Hiba.
Thank you very much, sir. Our next speaker will be Dr. Srinivasan Rajagopala. So he's a director of pulmonology and sleep medicine, along with director of transplant, pulmonology, and lung failure unit at Kauvery Hospital, Chennai. Doctor is a distinguished specialist with an impressive background in pulmonology, intensive care, epidemiology and statistics, and transplant pulmonology. With a wealth of experience spanning over 2 decades, he has made significant contributions to the medical field through his work at esteemed institutions both nationally and internationally. His research findings and insights have been published in esteemed national and international medical journals. Moreover, he serves as a reviewer for several such journals. He'll be now making his presentation on risk factor reduction. So, welcome, sir. The floor is all yours.
Thank you, Iba, for those kind words. Can I have the first slide? So, as Dr. Deepchand pointed out, atrial fibrillation is a common problem, and we see patients who, might present directly with symptoms suggest of atrial fibrillation. They present to the cardiologist or the electrophysiologist, like Dr. Deepchand. But often we have patients who will have an underlying lung illness, and atrial fibrillation may complicate their underlying illness. So it may be both ways as well. So in terms of atrial fibrillation, one thing that has already come out in the discussion so far, a common risk factor is aging. So as age advances, atrial fibrillation in the population increases. Beyond 80 years, it's 1 in 10, as has already been pointed out. Obviously, somebody with underlying cardiac disease has the substrate of atrial fibrillation because of the chambers being abnormal and conduction being abnormal. And this is especially true for people with left-sided disease. People with hypertension, again, especially if the blood pressure is uncontrolled over a long time, they have the substrate for developing atrial fibrillation. And sometimes the symptoms under hypertension can first be diagnosed when they present with atrial fibrillation as well. Again, uncontrolled sugars or lipids and a family history of atrial fibrillation are risk factors. But of late, the single most important risk factor we see, and this is both ways, patients who present to Dr. Deepchand and this atrial fibrillation is not getting controlled easily, then they're sent to me for evaluation of possible sleep disorders, and we diagnose sleep disorders very frequently in this population. But conversely, people who come to me with sleep symptoms, I find atrial fibrillation as a unrecognized comorbidity in them very frequently as well. So obesity going together with sleep disordered breathing is very common in the community. In Indian data, the data suggests that actually 26 to about 35% can have significant sleep disordered breathing in the community itself. So unselected people in the community itself, 1 in 3 can have significant sleep disordered breathing. So it is as common as that. And if you look at the severe subset of this population, roughly 1 in 10 will have severe sleep disordered breathing. By sleep disordered breathing, what we mean is heavy regular, every time when you go to sleep, there is heavy snoring. This may be associated with witnessed apnea. That is, the partner identifies that the breathing is not regular. There is cessation sometimes in breathing, and there is a deep inhalation followed by this cessation. Your sleep is unrestorative. That is, you slept, but then at the end of waking up, you feel that you have not slept enough. You feel groggy. You may have headaches in the morning. And as the day progresses, you're not able to concentrate much. You feel sleepy. Especially this is accentuated when we are not concentrating in work or after a meal. So these are all symptoms of sleep apnea, and this is a very unrecognized problem in the community. And obesity is often the single big risk factors, and this is often associated with insulin resistance and diabetes and hypertension. So these all go together, and these are all strong risk factors for sleep apnea. In obstructive sleep apnea, what happens is that there is periodic cessation in flow because there is obstruction in the upper airway at multiple levels. So air does not get to your lungs, so oxygen is not extracted from from the lungs. So your oxygen level falls, and this happens cyclically because oxygen is needed for your brain to work and for all organs to work. Then we move from a deep level of sleep to a superficial level of sleep, or we get awake. And because when we are awake, then consciousness causes neuromuscular tone to the upper airways, and the upper airways open up. So then there is no normal flow, normal oxygen, and then there, because you're on normal oxygen, you go back to sleep, and the same cycle repeats. This may repeat as many times as 100 per hour. That is, you're waking almost 100 times an hour. And these episodes are associated with low oxygen. This low oxygen is then a stressor for the heart. Also, the fact that you're swinging your chest muscles so much to get in oxygen and air into your chest is also a stressor on the heart. All of them cause, heart rhythm abnormalities, and that is why this is the single most important risk factor that we are now recognizing for atrial fibrillation. Of course, patients, these episodes can be triggered by particular events that happen, like, for example, a surgery, especially cardiac surgery, thyroid disease, patterns of abuse, like, for example, a binge of alcohol abuse, or a viral infection with pericarditis, or a blood clot going into the lungs. So these can be episodes. Can I have the next slide, please? So having known that these are the risk factors, how do we kind of mitigate these risk factors? If you look at lifestyle modification, healthy lifestyle with a balanced diet, a regular exercise program, and weight reduction to keep your BMI between 23 to 25, good sleep hygiene, that is a good 7 to 8 hours sleep, undisturbed sleep is important, the regular sleeping schedule, avoiding excess of caffeine, certainly no more than 3 cups per day, or avoiding smoking and or stopping smoking if anyone is smoking. That has a host of other beneficial effects apart from heart rhythm issues as well. And of course, certainly somebody with atrial fibrillation, all this becomes very important to control the rate. Salt restriction is important, especially if this is concurrent hypertension, but also in patients with atrial fibrillation as well who have heart failure. Good pressure control of blood pressure, blood sugars, and lipids, and certainly to evaluate for sleep disorders, and to manage the sleep disorders is important to control the atrial fibrillation along with the other things that are going to come out in the subsequent talk. So I think these are important measures to reduce the chance of having atrial fibrillation or to control atrial fibrillation once it has already happened. I hand over to you, Dr. Deepcha.
Thank you very much, sir, for that lovely presentation. Also, to all the audience, in case you have any questions, you can always type them in the question answer box, and post the presentations, the doctors will be answering all the questions for you. So please make use of this opportunity and type all your questions in the Q&A box in the Zoom chat given below. All right, so our next speaker now will be Dr. Sivarajan Tandeshwaran. He is a senior consultant, stroke and neurovascular medicine, Kauvery Hospital, Chennai. He has a super specialization in areas of stroke medicine, neuro rehabilitation, neurointensive care, general internal medicine, and gerontology. His special interests in headache, Parkinson's, and dementia, and he also has specialization in advanced MRI imaging and research interest in acute stroke, neurodegenerative disorders, and neuronal plasticity. His major achievements include research poster presentation at the European Stroke Organization Conference 2015, oral presentation in European Stroke Conference France 2014, and he also has his publications in international journals including Brain, American Journal of Neuroradiology, and poster presentations at various stroke conferences across the globe. He's also won a lot of awards, so it's lovely to have him here today. His topic will be the link between atrial fibrillation and stroke and how to reduce the risk of stroke with atrial fibrillation. Welcome, sir. The floor is all yours.
Very good morning, and thanks for your kind introduction. And Thanks to Dr. Deepchand and Dr. Srinivas Rajagopala for setting the stage on the importance of AFib, the risk factors, and how to reduce those risk factors. And one of the most feared complications of AFib, of course, is a stroke. And stroke is one of the leading cause of death and disability next to cancer across the globe. And may I go to my slides, please? And as we know, the risk of stroke has been increasing exponentially across the world, and especially in India. Stroke used to be a disease of old age in those days when we were in training, but now we see stroke happening in youngsters too. And as Dr. Deep and Dr. Joseph may agree, the risk of heart disease are increased exponentially in youngsters also. So I'm not able to see my slide. Are you able to see those slides?
Yeah, but the screen share is on.
Okay.
Yeah, the slide shows four pillars of atrial fibrillation management, and stroke risk is
Yeah.
on the slide right now.
Oh, yeah, that's right.
Now
Thank you.
it's flipped.
So when we look at AF, it increases a stroke by almost five-fold compared to other risk factors. And almost 30% of strokes are due to atrial fibrillation. And atrial fibrillation, as Dr. explained, it increases chaotic rhythm in the upper house of the heart, and it leads to stagnant blood flow in the left atrial appendage. And when the clot accidentally moves out of the appendage, it can travel up the carotids or anywhere in the body and cause embolic events. And if it happens to be in the brain, it can cause a stroke. And 80% of strokes are due to embolic, thromboembolic reason, where there is a block in the blood vessel causing starvation of blood and oxygen. So almost 30% of strokes are due to atrial fibrillation, and in about 40% stroke is the first sign of them having an atrial fibrillation. So that means there is a lot of room to catch up where we can prevent these devastating strokes by screening patients in the community. There are a lot of ways we can screen, and which Dr. Deep and Dr. Joseph may explain later. And worldwide, almost 1 million AF strokes happen every year. There's a huge opportunity here for us to screen these patients and prevent these big strokes. Often, AF related strokes have very high mortality, mainly because these clots are much larger in size and they can block larger arteries like the whole middle cerebral or anterior cerebral arteries, compared to other lacunar strokes where the stroke size is smaller. And AF risk increases with age, as doctors explained. Almost 10% of individuals above 80 happen to have atrial fibrillation. So there is a huge need to screen above 60 years of age and reduce those risks. As you can see, the slides showing the brain scans, you can have a variety of strokes with atrial fibrillation where the whole brain is affected, or there are multiple territories with small strokes that can be affected. Often, by looking at a scan, we can say whether the person's risk factors due to stroke from atrial fibrillation or else due to hypertension, diabetes, or otherwise. Next slide, please. So apart from having atrial fibrillation, there are other risk factors that come to play in leading up to a stroke. So that we do see a lot of individuals who have atrial fibrillation for several years, but they may not have had a stroke. But there are individuals who just happen to have developed AF and then they end up having a stroke. So what other risk factors that may accentuate the risk of stroke in those with AF is multiple, and that includes congestive heart failure, hypertension, older age, poorly controlled diabetes, which all lead to scarring in the atrial uh, wall, increasing atrial cardiomyopathy, and so on. And there may be other risk factors which causes sticky blood situations where there may be increased inflammatory states or congenital clotting dysfunction because of acquired or congenital reasons. And we did see a lot of strokes during COVID, and that might be because of increased inflammation in the heart muscle, also in the blood vessels, and also in the change in the blood milieu of how the clotting and anti-clotting factors worked with COVID inflammation. And apart from that, there are a lot of other risk factors concerning to the size of the left atrium, the left atrial appendage architecture, and so on. Next slide, please. So how do we judge if somebody with AF would develop, what are the risk factors they may, uh, what is the risk of them having a stroke when we know that somebody has got atrial fibrillation? So this particular score called CHATS DS2 VASC score, or CHATS2 VASC score risk calculator is a very handy tool. This can be used by anybody in the community. For example, if somebody who's 75 with hypertension and diabetes, the risk of having a stroke, so they would score at least 4 on the scale, and if the score is 4, the annual adjusted stroke rate is almost 4%. If they also happen to have had a TIA in the past, or if they've had a thromboembolic phenomena like a DVT, then you add 2 points on top, and the risk increases to almost 10%. So it's a very simple tool that can be used by anybody in the community just by putting those numbers against the risk factors. So this is a very good tool that can help us to identify those who would need treatment. So, for example, according to the scale, if somebody has a risk score of 1, then straight away they are recommended to have treatment with blood thinners called anticoagulants. The score is 2 and above, they must be given anticoagulation unless there are other risk factors which may preclude them from taking these medicines. Next slide, please. So, apart from sudden stroke risk, there is also a huge link between cognitive decline in those with atrial fibrillation and also risk of developing vascular dementia. So that's simply because with long-standing AF, apart from having acute strokes, individuals can develop silent strokes in the brain, wherein a lot of small scars, tiny scars can develop across the brain, and that can lead to slowing in their brain reflexes, slowing in their muscle reflexes. They may often end up needing help with day-to-day activities at home because of increased risk of falls at home. They may end up with bladder incontinence and so on. Next slide, please. So as you can see on this slide, there is no single area of stroke, but the individual has developed multiple small silent areas of scars in the brain. And this is another risk factor that needs to be addressed in those with atrial fibrillation. Next slide, please. So how do we prevent stroke? So there are multiple ways we can do it. And this is a data from United States, but it holds good to India too. So there are multiple preventive strategies. There are antiplatelets, we have warfarin, and also the newer anticoagulants that can be used. Antiplatelets reduce the risk by about 20%, but the newer agents like NOACs and also warfarin, which has been used for many years, reduces stroke risk by almost 2/3. And in those who can't take anticoagulants, then we have other options wherein experts like cardiology, interventional cardiologists, and Dr. Egyptian can help us with closing those left atrial appendage with devices, or it could be surgical occlusion of those devices. Next slide, please. So when we have somebody with a stroke and we know that they have got atrial fibrillation, obviously we have to be careful about how we manage at the acute stage of stroke. So if it is a mini stroke called TIA, we can start these medicines within the first day because these are very small strokes wherein the bleeding risk after stroke is not massive. If they are mild to moderate risk, depending upon the size of the stroke, we can start these medicines between 3 to 5 days. And those with very large strokes, we can still start these medicines in about roughly 12 to 14 days time. So we do put in a lot of other calculators to make sure they do get the full benefit of the medicines and reduce further risk. For example, if somebody has got AF and stroke, the risk of recurrent stroke is very high. It's almost 1.5 times higher with every passing day. So that's the urgency in starting these medicine, these patients, to avoid further damage to the brain. Next slide, please. So there are benefits and disadvantages between warfarin and the newer agents. So roughly speaking, warfarin is a very time-tested medicine and with good stroke reducing benefits. But the problem with warfarin is it has got significant food and drug interactions, and it has constant need for blood level monitoring. And often patients who are on warfarin, they don't stay at optimal time and therapeutic range, especially those who come from rural areas. They don't get the importance of proper monitoring of the blood levels called INR testing. And we do see patients who are undertreated coming back with strokes because they have not been taking these medicines in the right manner. So with the newer agents, we don't need any monitoring, and they are very easy to use. And but there are certain contraindications using the newer agents where somebody had a previous rheumatic mitral valve disease or valvular heart disease, or if they have a metallic valve, they can't use these medicines. But that subset of population is very tiny. Um, the small disadvantage with the newer agents is they don't have an antidote if they come in with a stroke. And there's only one drug that has got antidote called dabigatran. And even that is a little costlier at this point in time. Next slide, please. So the challenges in reducing stroke due to AF is, the first thing is to detect these AFs. There are a lot of patients who can be easily prevented from stroke due to AF. And next thing is to make sure patients take these medicines adequately and the compliance to medicines. And the third is, while somebody is on treatment, the risk of bleeding is higher. And when somebody is on medicines for AF and they may come in with a newer stroke, there's a bit of dilemma whether we can give so the clot busting medicines or not. And in these scenarios, we may have to take them straight to a mechanical clot removal called thrombectomy. And across India, the infrastructure and the specialists dealing with thrombectomy is increasing, luckily, in India. And not many places, for example, if you're in BLC centers, there are not many cath labs with thrombectomy facilities. But if you're lucky and living in an urban area, you may have the option of having thrombectomy when you come in with a stroke while on blood thinning medicine. And obviously, we have to keep watch on other risk factors while on treatment, like diabetes, hypertension, congestive heart failure. And as we increase in age, for example, above 90, the risk of the benefit of oral anticoagulants decreases because of increasing false risk. So it's not that we can give this medicine as a blanket to everybody, but we also have to keep monitoring to make sure they don't end up on the other side of risk while they're on treatment. Thank you. I think I'll stop here and take questions later.
Thank you very much, sir, for that lovely presentation. Also, again, remind the audience, in case you have any questions, you can put them up in the question answer box, and they'll be posted to the doctors once the presentations are done, and then we can have a good discussion based on all your questions. So thank you very much. And our final panelist will be Dr. Joseph, a consultant interventional cardiologist and electrophysiologist at Kauvery Hospital, Heart City, Trichy. He's an expert in special procedures, including 2D and 3D EPS plus RFA, HIS bundle and self bundle pacing, leadless pacemaker extraction, transplant care, and has completed over 1,000 plus angiograms and angioplasty. He'll be along with Dr. Deep, and they'll present on the topic rate and rhythm control of atrial fibrillation. Welcome, gentlemen. The floor is all yours.
Thank you, the Hindu, and also thanks for Dr. Srinivas and Dr. Sivarajan for setting up the tone. So probably Deep might have some slides also. So when we start with AFib, I think now we have gone through the risk factors. We know that there is a risk factor for AFib management, AFib prevention, and also there is a morbidity and mortality associated with AFib. So now it is the time for us to really treat the AFib from the cardiac point of view. So there are two ways to treat the AFib. That is either by controlling the rate or the rhythm. Okay, anytime. Okay, rhythm control is far better than rate control. So when you classify AFib into three types. That is paroxysmal AFib, persistent AFib, or a long-standing permanent AFib. So these three types, if it is a paroxysmal AFib, it's going to last from few seconds to at least a week. And it might sometimes spontaneously terminate within 48 hours. So you need not do anything for that. But on the other hand, if it's a persistent AFib, it's going to last for more than a week. And if it's going to be a permanent AFib or long-standing AFib, it's going to last at least more than a year. So you classify this into 3 types and then decide your treatment according to that. So whenever AFib is a spectrum of disease, it doesn't really start from paroxysmal and remains paroxysmal. It starts as a paroxysmal AFib, it might go into a persistent AFib and then go into a permanent AFib. So sometimes the symptoms might come, the palpitations might be there, and the symptoms might be for a brief period of time, it might spontaneously subside. So it doesn't mean the disease has subsided. You need to really look at an electrophysiologist or a cardiologist and make sure the risk factors, your trigger factors are being addressed to. That is very elegantly put by Dr. Srinivas. Whenever there is an AFib, you need to look for your risk factors, especially the reversible risk factors. Sleep apnea, alcohol intake, or thyroid, all those things. So these things have to be looked into it. If those things are there, you can be very easily reversed by correcting a systemic problem. But on the other hand, if it is a per se cardiac issue, in those kind of scenarios, you need to go for a rate control or a rhythm control. So when you look at the medications which are used for controlling the rate, it is beta blockers, calcium channel blockers, all those things are very much available. And whenever it comes back, we use sometimes called as a pill in a pocket approach, where we give the patients some tablets, some medications, which can be used when they develop a paroxysmal or persistent AFib. So next slide.
Yeah. So, Joseph, so the next slide is on the procedure. So, you had introduced to the audience about the medications. The medications are the primary way that we start treating atrial fibrillation. But then, as you had exactly put out, atrial fibrillation is a progressive problem. Many patients who are on paroxysmal AFibs progress to persistent and then to long-standing permanent atrial fibrillation. So depending on which category of patients and which part of the natural history we catch the patient, the patient presents to us, we offer different procedures. First, if the patients are only paroxysmal, we start with medications, but the patients keep getting this AFib episode, then we offer procedures like percutaneous non-surgical procedures. The most common of them is the electrophysiology study. And as a lot of studies have pointed out, these pulmonary veins that are the sources of paroxysmal atrial fibrillation. And if we can successfully isolate these pulmonary veins, that will reduce the incidence of further incidences of atrial fibrillation in the future, and it will improve the quality of the life dramatically in those patients. And then the other percutaneous non-surgical procedure, which Dr. Sivarajan, neurologist, had already pointed out, will have to reduce the stroke risk, because it is this appendage where the clot forms and which can embolize and cause the stroke. But there are not all patients who are suitable for blood thinners. There are patients who might have a high bleeding risk, and they may not be suitable candidates for blood thinners. In those patients, we might need to close this appendage with options called left atrial appendage closure devices, and then that is to reduce the stroke risk. And then, Dr. Joseph, you can add more to us about the other strategy for managing atrial fibrillation, which is in front of you.
There are some times where we will not be really able to control the rhythm. In those kind of scenarios, what we do is, as was alluded to, there is upper house disorder in an AFib. Okay, so I usually tell my patients that atrial fib is like heart has 2 chambers. The upper part is the tank, and the lower part is the pump. So upper part takes in the blood, gives it to the lower part, and then fills the pump, and the heart pumps the blood into the systemic circulation. So in this scenario, the upper tank is in a chaotic rhythm. So what we do in these kind of scenarios is, that is, either your medications doesn't work or neither of your ablation doesn't work. What we do is something like an AV nodal ablation. That is, you damage the point at which the upper impulses are going into the lower chamber. So those are the areas where you damage it, and you cut off the impulses from the upper chamber to the lower chamber and put a pacemaker in the lower chamber, so that your heart rhythm is maintained. So this is how, in cases of long-standing permanent AFib, when you want to really control your heart rate and prevent the LV dysfunction which might come out of AFib, which we do in a scenarios where we are not able to take control of the rate or the rhythm in many of the patients. Deep.
Yes, thank you, Dr. Joseph, for that. So we will conclude with this slide. So the take-home messages are the four pillars of AFib management. We had Dr. Srinivasa Rajagopalan talk about the risk factor reduction, which is the paramount, which is the most important thing whenever we see a patient. Is he obese? Is he having obstructive sleep apnea, diabetes, hypertension? How well are they controlled? And is he under some sort of a substance abuse? We go through all these checklists and we try to address these risk factors. And then the other pillar of the AFib management is the stroke risk. Stroke is a very debilitating illness because of atrial fibrillation. We need to identify, involve the neurologist at the right point of time, assess the risk for the stroke, and keep these patients on blood thinners so that they don't get a stroke in the future. And then, of course, we have medications for rate control and to keep the rhythm under check as well. And in case the rate and the rhythm control medications don't work, then we have procedures in our hand, like the electrophysiology studies, ablations, and in the end stage, Dr. Joseph had beautifully pointed out, for patients with heart failure, we have no other option left. We can cut off the wire between the upper and the lower house and then put a pacemaker in. That will be the last step. Thank you.
Thank you.
Thank
Thank
you.
you very much, doctors, for that very insightful, knowledgeable session. I'm sure, like the audience, even I had so much to learn from. So thank you very much for giving us your time. We will now move on to the question answer session, the most awaited session. We have about 10 questions that few of them were already answered. We have few more. So whoever wishes to answer can unmute and give us the answer for it. So our first question goes, what should be the line of management in the cases of paroxysmal atrial fibrillation, where the frequency of attacks is 6 to 9 months? Whichever doctor wishes to answer can unmute and give us the answer.
Deep.
Yes, so yeah, I mean, paroxysmal atrial fibrillation is a very early stage of atrial fibrillation. We would ideally put these medications on some rhythm control medicines, and these rhythm control medicines we hope will keep the atrial fibrillation under check. And there are a few medicines which we do not prefer at a younger age, and there are a few medicines which we prefer at an older age. It depends upon the age that we prescribe these medicines. If the medicines do not work, we will offer something called an AF ablation, pulmonary vein isolation, for these patients, because we do not want these patients to progress from paroxysmal AFib to what we call a permanent atrial fibrillation.
True. If I could add to it,
Please.
one thing is, most of these patients, since the frequency of attack is around 6 to at least once in 6 months, this patient has to be consulted by a cardiologist. He has to get an echo done, because many a times these patients remain asymptomatic, and many of these AFibs might be asymptomatic, and they might develop a valvular regurgitation, mitral regurgitation. So this patient has to consult a cardiologist before this patient is kept on medications.
Yes, thank you very much, doctor, both of you, for adding on points to that question. Our next question goes, I am 33 and in my recent echo, it was mentioned grade 1 diastolic dysfunction. What should be taking care and what's the remedy? Whichever doctor wishes to answer can give us the answer.
Yes.
Yeah. So grade 1 diastolic dysfunction is sometimes a very benign thing. Okay. Basically, diastolic dysfunction here means that your heart is pumping well, but the elasticity of your heart is slightly gone. That is like the filling of a heart is slightly defective. So this can happen in patients with hypertension, diabetes, or elderly people. So if he's 33 and has got a grade 1 diastolic dysfunction, sometimes it can be normal since it's only a grade 1. Okay, if he's obese or something like that, he might have this grade 1 diastolic dysfunction. But if he's not obese, this might be a benign findings, and he need not be taking any medications for this. But a proper consult from the cardiologist is always required.
Thank you very much, doctor, for giving us the answer for that. We'll move on to our next question. It goes, is it advisable for a stroke patient to drive vehicles after recovery?
It's a very good question, and we usually advise not to drive for at least 30 days after a TIA or mini stroke, and we'll have to reassess how they are at the 30th day clinic visit to make sure they are fit to drive. If somebody has a disabling stroke, obviously we have to assess and make sure their reflexes are preserved, and if they have very good motor control to make sure they can drive. In Western world, like in the UK or America, people have to notify the driving authority, the DVLA in the UK. But I don't think we have such rules in India yet, and it should actually be there in a developing world like us. And a lot of patients have come back to us and say, "Doctor, I've started driving," and we get a little worried about them driving on the roads when the risk is still out there. So yes, it's a guarded response, and we have to make sure they are okay to drive. And the same goes to flying. We advise patients not to fly for at least a month after mini stroke or stroke.
I'd like to add, in terms of driving, another important thing in atrial fibrillation is sleep apnea. So, unrecognized sleep apnea is one of the common causes for, or at least sleep, abnormal sleep is one of the most common causes for road traffic accidents, apart from alcohol intoxication. So, because people have significant sleep apnea, and I've said 1 in 3 can have significant sleep apnea in the community, poor quality of sleep especially becomes, we are driving along along the highways and it's monotonous. Your brain then goes into a fade, and this leads to momentary distraction, which can lead to accidents. So unrecognized sleep apnea is, it's important. So somebody having atrial fibrillation to also consider this, and this may be concurrent with the stroke. So a lot of patients with stroke also have sleep disorders. So it's important to recognize that as well before considering driving.
That is very true. We have had patients who complain to us that they go to sleep when the red signal and the traffic signal is on. They quickly go to a sleep for 30 seconds or so. And these are the patients should understand that there's something not right with their body. They do not have a good sleep, the brain fatigue. They should get themselves evaluated for obstructive sleep apnea. And of course, they have very high risk for atrial fibrillation and stroke in these patients.
Thank you very much, doctors, for adding to that question. We'll go to our next question. It goes, is RBBB related to atrial fibrillation?
And not really. RBB means a right bundle branch block. It could be most often an incidental finding, which is seen in the electrocardiogram, and it may not have a direct relation to atrial fibrillation. There are other important predictors on the ECG, like the P wave duration and other sort of things, and the echocardiographic parameters. So, not really is that a direct relationship between these two.
We can just add, like Dr. Deepchand pointed out, but then often these patients with RBBB can have underlying lung disease, and that can be associated with atrial fibrillation. So indirectly, it can be like Dr. Deepchand said, directly no, but indirectly, if you had significant lung disease or even significant sleep disorders, you can have RBBB associated with atrial fibrillation.
Thank you very much, doctors, for adding to that question. We'll move on to our next one. It goes, what are the preventive ways to strokes and other related issues at a younger age? Because due to academic stress and work issues, the palpitations are more frequent in some people.
Yes. Okay. So we are seeing an epidemic of stroke in younger individuals, especially those who work in software industry, and often they work very long hours and they have a lot of work stress, and they sit for several hours a day. Sitting is the new smoking, and that leads to a lot of other hormonal and metabolic issues in the body. Uh, Stress, especially in younger population, is a huge concern, and I mean, to avoid stroke, one has to be fit and healthy. We recommend at least a minimum of 5,000 to 7,000 steps of walk a day, or intense physical training for at least 20 minutes a day. And obviously, with the youngsters, a few of them indulging in alcohol and drugs, that increases their stroke risk massively. And we have to make sure they have good relaxation techniques, maybe participate in yoga sessions, meditate, and having a healthy lifestyle reduces risk. um, I mean, talking to a psychologist or big companies having a psychology counselor can also help in individuals overcoming stress. So these are things people can do individually, and also organizations, big organizations who employ larger group of individuals can help.
Thank you very much, sir, for adding to that question. We'll move on to our next one. It goes, how can an ordinary person distinguish between panic attacks and atrial fibrillation, both of which increase heart rate?
Yeah, panic attacks basically is always precipitated by some kind of a physical or emotional stress. So that need not be all the time with an atrial fibrillation. Okay, so the scenario in which it sets in, okay, that itself will tell you that either it might be a panic attack or an AFib. So if a person can read a bit of ECG, okay, you can always say that if there is a panic attack, there will be something called a sinus tachycardia. Okay, the rhythm will be regular. Okay, between two beats, the rhythm will be regular. But AFib, the telltale of a remarkable thing of AFib is the rhythm is irregular. Okay, it will be completely irregular, chaotic. So if you have a smartwatch and you can record your ECG during that time, you'll be able to find out whether there's an AFib or a panic attack. Okay, because if the rhythm is regular, it is mostly panic attack, and if it is irregular rhythm, it is an AFib.
But I'd like to add that both panic attacks and atrial fibrillations are significant issues which the common person should not try to distinguish themselves, but should probably show somebody, at least a general physician, if not a cardiologist, before considering one or the other.
Thank you very much, sir, for adding to that question. We'll move on to our next one. What about a person with HOCM? Is there a way to naturally control the rate and rhythm of the heart?
So HOCM is hypertrophic obstructive cardiomyopathy, which is meaning disease of the heart muscle, and the heart muscle is abnormally increased in size, thickness, and the mass. It weighs more than the usual heart. So whenever one has this cardiomyopathy, they have a lot of heart rhythm problems accompanying the cardiomyopathy. Most dangerous of them is the ventricular tachycardias and fibrillations, and then a lot of them have do atrial fibrillations also. Natural way to control the rate and the rhythm of the heart. Uh, See, something, there have been a few studies on vagal nerve exercises. This is interesting region where you stimulate your vocal cords. For example, it's common in Indians to tell that the sound of om or some other vowels where you trigger your vocal cords for a long period of time. These are vagal nerve exercises which can keep your heart rate down. So we do suggest vagal nerve exercises to some of the patients to prevent breathing exercises, as I pointed out earlier. Breathing exercises, they have a definite link with the heart rhythms and the electrical wires. These breathing exercises can definitely lead to a healthier electrical system of the heart. So these are the only natural ways that we usually suggest uh, for anyone with who can predict or predicted to have heart arrhythmias. We say, why don't you do all those things, breathing exercises, meditations, and avoiding caffeine and all those things, so that you can stay away from these heart rhythm problems.
Thank you very much, doctor, for giving us the answer to that question. Our next question goes, a mom had multiple blood clots like a shower in brain. ECG showed tachycardia. Is it related? Does it mean she had atrial fibrillation?
So often patients, as I said, almost 40% of patients may present with stroke, may have atrial fibrillation as the actual event. And all tachycardias are not AF, and it may be simple sinus tachycardia. But in patients with in the patients with stroke, we do screen them routinely for AF. All patients who come in with AF above 60, or even in younger individuals, if they have the right risk factors, apart from 12 lead ECG, we do perform a Holter monitor extended for about 24 hours, even up to 5 to 7 days. So, in a 12 lead ECG, the pickup rate for stroke is very, very small, less than 1%. When we do it for 7 days, it goes up to 5%. And when we do it for almost a month in certain regions where we still think AF could be the main reason for stroke, the pickup rate goes even up to 30%. And roughly about 20% of patients with stroke, we may not find a cause even after extensive testing, and they call cryptogenic strokes. In those individuals who are deemed to have no risk factors identified at the onset of stroke, over a longitudinal monitoring, almost half of them end up having atrial fibrillation as the main cause of stroke. So AF is a very, very important risk factor in stroke. So we would recommend the person's mother to have a Holter monitor to see if they have paroxysmal AF or uh, other rhythm disorders.
Thank you very much, sir, for answering that for us. We'll move on to our next question. It goes, is there any risk in taking blood thinners?
So before we introduce blood thinners, we would assess the risk of bleeding in the individual, and it is an individualistic decision. And the risk of bleeding is small compared to the benefits of stopping a clot. So yes, there is a small risk, and the risk is based on other risk factors. If somebody has diabetes and uncontrolled hypertension, we would worry a little more. But if all those other risk factors are nicely controlled, then the bleeding risk from blood thinners are very minimal.
Thank you very much, sir, for giving us the answer. We hope it answered the question of the person who asked it. We'll move on to our next question. It goes, I'm 30, under medication for migraine, Valence OD 500, Nexito Plus, and hypothyroidism, also taking Rosuas 5 mg on doctor's advice once a day since last year. For few months, my hands feel weak and I drop things off my hands, and I intend to use an object, it slightly deviates. Could it be pre-symptoms of a stroke or anything like that?
No, it doesn't sound typical of a stroke. It may be because of other reasons. If somebody keeps dropping objects accidentally, and if it is more frequent, then we would think of other possibilities, like if they have any muscle weakness in the hands, or sometimes absence attacks. It may be a precursor of some electrical disturbance in the brain. I don't want to scare them with the word epilepsy, but it's very easy to come and talk to us in person because there's a lot of other issues that we look into.
Thank you very much, sir, for adding to that question. We'll move on to our next one. What are the regular physical activities and diet control to avoid these four pillars of AFib?
So we spoke already about certain measures to reduce the risk of atrial fibrillation. That is one of the pillars and of management of atrial fibrillation. Mainly to reiterate, a balanced diet, a regular exercise program, control of weight, a management of medical comorbidities like hypertension, diabetes, and abnormal lipids, having a good sleep hygiene, and recognizing possibility of any sleep disordered breathing are important. There are some medical disorders which are associated with atrial fibrillation. So recognizing symptoms of those common blood disorders like thyroid disorders, etc., and is important. In terms of diet, there is no particular diet which is directly related to atrial fibrillation. But in people with hypertension and cholesterol, low salt diet and a diet which is low in saturated or unsaturated lipids is important. So that would anyway be covered under a balanced, healthy diet. So no, there is no direct relation of a particular diet to atrial fibrillation as far as I
Thank you very much, sir, for answering to that question. We'll move on to our next one. It says, I'm 63 years old and I've been taking medication for AF paroxysmal. ICD was implanted 4 years ago. Now I've started getting choking sensation in the throat, followed by pain in the shoulder and dizziness. What should I do?
Not sure whether the history is not complete because patient has got AFib, paroxysmal AFib. I'm not sure why ICD was implanted for it. But still, if the patient has got a choking sensation in the throat, okay, this definitely requires the patient to visit a cardiologist and rule out a coronary artery disease because a patient has already been implanted on ICD. I think the history is half complete. We cannot extrapolate it too much.
Yeah, I'd also like to add if the choking sensation is during sleep, then probably despite using a CPAP device, your sleep problem is probably not controlled. It's common misconception that using a CPAP equals normal sleep, but actually that is a device which needs to be titrated and adjusted. Yeah, it needs a periodic review at least once every 4 months to see if the sleep disordered breathing is okay with your CPAP machine. This is just like hypertension and taking blood, antihypertensives. You've taken antihypertensives does not mean automatically your blood pressure is controlled. You need to monitor your blood pressure to make sure your blood pressure is controlled, despite being regular with your pills, adjusting your pills to get your blood pressure under control. So, a review of the CPAP usage with the sleep specialist is also important.
Thank you very much, sir, for answering that question for us. Our next question goes, what are the do's and don'ts we need to follow in attending stroke patients before help arrives?
So yes, it's a very, very nice question. So before help arrives, it is ideal to make sure they are in a relatively safe position, what we call as a recovery position, where we um, put the person in one side of the body, like a left lateral position, and with the hand under the head, if possible, or just a pillow under the head. The reason is if they have increasing brain pressure, they may start vomiting, and if they are kept sitting up or kept on the back, they can aspirate the vomit. That's the ideal thing to do. And a lot of times, individuals have said, "Oh, I've given 4 tablets of aspirin at home." That's what the doctor advised when somebody had a heart attack. But this should not be done in stroke patients, because a stroke can sometimes be due to a bleed, which can increase in size as they come into hospital if they had been given aspirin. So no medicines to be given. Just make sure they are safe and call for an ambulance. It's better to come in an ambulance than come in your own transport, because while you're moving and handling, you can injure certain joints or even hurt the person. And again, when you're in transit, if somebody develops a seizure, if you're an ambulance, they can give medicines to immediately abort it and give oxygen support and so on. So best thing is to just wait for help and not to give any medicines.
Thank you very much, doctor, for giving us the answer to that question. Our next question goes, what are the chances of having a flutter in long-standing AFib? Is it more dangerous?
Oh, actually, it's the other way around. Patients with atrial flutter, if not recognized properly or at an early stage, these are the patients who would land up with atrial fibrillation in the long term. And when we mean flutter, is the atrial flutter, the upper house flutter. When the lower house goes into flutter, is basically you're in deep trouble, because that's a very bad sign. So, when a patient has an atrial flutter for a long period of time, the chances that this atrial flutter will translate into atrial fibrillation. So, they need to see the cardiologist, the cardiac electrophysiologist, and have that sorted out.
Thank you very much, doctor, for answering that question. Our next question goes, does HOCM have hereditary links?
Yes, of course. Hypertrophic cardiomyopathies, any cardiomyopathy for that matter, at least 15 to 20 percentage of them are familial, which means they have a strong genetic predisposition. Either it runs in the family, or they have some de novo mutations, which means they have acquired some mutations in their lifespan, and that has led to these heart muscle disorders.
Thank you very much, doctor, for answering that. Our next question goes, how do I identify that I have any cognitive impairment? How to overcome those?
So usually it starts insidiously, and it may not be easily observed by individuals in the same household, because they often take it for granted that, oh, this is happening because of aging and so on. Often, when your relatives or friends come to visit, often they pick it up that, oh, you're forgetting more, and quite often it may be, if it is very obvious, then the family members can easily identify. So it's very common for us to forget where we left our keys or spectacles and remote and so on. But if it gets in the way of our day-to-day activity, like when you're going for shopping, if you're forgetting half of your items, or if you're forgetting anniversaries, and also not remembering your paying your bills and so on, then it becomes a bit more obvious. So if you have any doubt, it's better to come and get it checked. And we do have scales, memory assessment scales, cognitive assessment scales, which we can use to check and advise on what next to be done.
Thank you very much, doctor, for adding to that question. The next question goes, can we climb the staircase more than 5 floors if my age is 40 plus?
Well, actually, the more you climb, the better off you are. So age should not prevent you from trying to climb stairs. So I would suggest that would depend on what is your baseline physical activity level. If your baseline physical activity is pretty good, say you're walking, at least 15,000 steps a day, then there should be no harm in trying to attempt 5 floors at one go. But if your baseline physical activity level is low, then you should probably start with a couple of steps, try to see how you're doing. If you're not having any symptoms, you should try to increase it till you get to wherever you want to be.
Thank you very much, doctor, for answering that question. Our next question goes, what is mitral valve prolapse? I'm not sure if I'm pronouncing it right, but that is the question. Please let us know the answer.
Fine. A mitral valve collapse is nothing but your heart has four valves. One of that valve is a mitral valve, and it's a left-sided valve which is present inside the heart. So, mitral valve collapse is something one of your leaflets for the valve. Okay, is slightly flexible and it prolapses. That is bends down. Okay, so that is called as mitral valve collapse, and it is a very benign condition. Okay, it happens in maybe frequencies around 2 in 100 people. So probably that should not be worrying when unless it doesn't cause a mitral valve leak.
Thank you very much, doctor, for answering that. I think this is our final question, which goes, is heart attack and AFib similar? Do we have
Absolutely
an answer?
not. AFib is a rhythm disorder, and heart attack is a disorder of the blood vessels. So, you get a clot inside your blood vessels supplying the heart, you get an heart attack. But on the other hand, AFib is a rhythm disorder. So, it's either you can call it as a systemic or an inflammatory or a degenerative disease of the heart, which affects only the rhythm, not the blood vessels of the heart.
I would want Dr. Srinivas to add on the CPAP management because we have had a number of patients we see who have had very bad sleep quality, daytime fatigue, and all those things. But when we once we send to him and they come back telling, so now I feel a lot of. He has given some magic machine. That magic machine works like magic. I put it in the night, and I'm feeling much better nowadays. So what is that CPAP machine, or what does it really do?
Right. So when there are different type of devices that are available for different sleep disorders. Now, when we said sleep disordered breathing, broadly, the types of sleep disordered breathing is obstructive sleep apnea. As is evident, there is obstruction, and this is at the upper airway level before air gets into your lungs. So this is usually typically at 1 or 2 levels or 3 levels. And there is a physical obstruction because of lower neurological output to those muscles while we are sleeping in the context of a narrowed anatomical space because of obesity or your skeleton, you're having retrognathia or some other reasons for the upper airway to be narrow. And then now you put on weight, and then that has all that fat has deposited in the upper airways. And then when you're sleeping, the passages become further narrow, and then it completely gets obstructed. So this is a pretty common problem. But apart from this, there are other causes of sleep disorder breathing, which is sleep hypoventilation syndrome. So that is not only is there obstruction, but then your breathing itself is slow or you don't breathe during sleep. So that not only causes oxygen to go down, but also causes carbon dioxide to go up. So that is also important. And there is a spectrum of other disorders in the sleep apnea spectrum as well. So now first thing we do is to find out what exactly is the problem by doing what we call a level 1 or a level 2 sleep study. So not only do we test if there is obstruction while you're sleeping, but what is happening to your brain activity, your level of sleep, is that associated with any heart rhythm abnormalities? Is that associated with the low oxygen level? How frequently is that low oxygen level happening? Is that associated with abnormal leg movements or any other abnormalities during sleep? Some people wake up during sleep and have activities that they don't remember. We call it parasomnias. They may have bruxism, so many other things happening during sleep. So we study that during either, depending on the severity, either witnessed, a complete study in the hospital, or if it's obvious and there is no other issue at stake, we may do an unobserved level 2 study at home as well. Once based on that report, we basically then decide whether what is the predominant problem. Is it an obstructive problem, or is it a hyperventilation or an allied problem? If it's an obstructive problem, then what we do is we pressurize the upper airway to a level which which kind of abolishes almost most of these episodes of obstruction. So the device basically what it does is it gives a constant level of pressure which will prevent the upper airways from closing. So it acts like a mechanical splint to your upper airways. Now this can be applied by two separate kind of devices, a manual CPAP or an automatic CPAP. So basically this is like a manual car where you put in 5 gears, or it's like an automatic car where you just the car decides itself. So, the manual car is as good, or in some cases better than the automatic CPAP machine. But the issue is that in a manual machine, you can put one pressure. So you generally choose a pressure where 95% of the episodes are abolished. Sometimes this pressure may be more than what is required, but it will abolish almost all these episodes. Whereas an automatic device, what it will do is it will basically be sending pulses down the tube, which is connected to the device, to find out if your upper airway is basically obstructed or not, and it will try to reduce the pressure to keep you more comfortable. So just as we know, like the more we try technology, like Boeing 737, you will have more crashes. So we try to kind of put limits to what the device does. And periodically review. Like if you put on weight, your pressure requirements will go up. If you lose weight, your pressure requirements will go down. So this is why we need to periodically reassess not only how good the patients are doing, how the blood pressure is controlled, what the device is doing as well. So this is why I said a periodic review every 4 monthly is needed. We do have other devices called BiPAP devices, which are required for more complicated sleep disorders or for patients not getting better with this particular kind of basic therapy.
Thank you very much, doctors, for that very, very insightful discussion. I think we've taken all the questions, but in case your question is still unanswered, you will get your response via email. So there's no worry about that. So this was a very, very hearty session, I would say, to involve the heart inside it. So big thanks to all the doctors and all the audiences and all those who questioned us and turned up today to make this session a very, very successful one. This was a webinar on 4 pillars of atrial fibrillation management presented by Kauvery Hospital under the Hindu Wellness Series. Thank you all. Have a great day ahead and take care of yourselves. Thank you very much, doctors, for tuning in today.
Thank
Thank
you.
you.